for joining us this morning for our Adolescent Health Mini Conference. My name is Dr. Latimer, and I have the pleasure of introducing our next two speakers. And hope that after Dr. Shaw and Angela Berger speak, that you'll continue to join us, to stay with us, where we'll have a panel with all three speakers and you can continue to ask questions. So thank you all for sticking with us and joining us today. So I'd like to introduce Dr. Parag Shah. Dr. Kasky mentioned that these two speakers are going to be joining us. Dr. Parag Shah is a hospitalist pediatrician at Lurie Children's, and he's also the medical director of the Transition to Adult Care program at Lurie Children's. He also is the hospitalist site lead at La Rabida, where he provides care for those patients that are medically complex. And Angela Berger is a licensed clinical social worker with over 20 years experience. And she works together with Dr. Shaw in the adult care program, the Transition to Adult Care program. And I personally work with them, and they have been very instrumental in helping our division provide better transition of care for our patients as they transition into adult care, especially our patients that are medically complex. So thank you so much for joining us today.
Thanks so much for having us. And I think I was on the chat earlier, and I can share my screen, right? To do my own slides. I think so,
Please
right?
Do.
Is that okay?
For you. Please do.
Oh, that'd be great. Let me see if that works. Okay, can people see the slides like flipping?
Yes, thank you.
Okay, great. All right, so thank you so much for that great introduction. And like I said, I'm Parag Shah, and on the line also, or on the panel also, is Angela Berger. We have the pleasure of working together over at Lurie Children's to help kind of Lurie Children's help them transition divisions, people, individuals, everything, make that transition to adult care. I'm going to thank Dr. Scott, on the previous presentation for setting this up really nicely, talking about adolescents, their pathway, their journey, some of the changes that they go through as they make the transition to adult care. And as you can see from the previous presentation, there is a lot of overlap. So I hope we can, just continue to build and talk specifically here in this case about transitioning to adult care. We kind of took the approach of building a program. So I'm assuming a lot of people on the line here are pediatricians, working pediatricians in offices or within programs or within larger institutions, or in whatever way, shape, or form people come on here on, what goes into a transition program from a program perspective. We have no financial disclosures. So we'll start off by talking about what is healthcare transition. And I know the references here are kind of old, but these have been reiterated. The gist is still the same as the evidence has changed. But the AAP does define healthcare transition as the purposeful and planned movement of adolescents and young adults with chronic physical and medical conditions from child-centered to adult-oriented healthcare systems. This has recently been expanded to include all adolescents, of course, that have to go through this process of transition. And we are finding that all adolescents need a little bit of help as they make this move. But what I like to highlight for most people is this purposeful and planned movement. And I think that highlights sort of the difference between, 30 or 40 years ago, what we used to think of as transition to adult care, compared to now, where we want this to be on our part, a purposeful and planned process. And just like you saw in the last presentation, is not look at the adolescents as a barrier, but look at us as enablers of this transition. I think the first thing, if you take nothing else out of this presentation, I think the big thing is to think about this as the process of transition does not necessarily the same as transferring the patient, although we will talk about transferring adolescents to adult care and how that's done. I think from our pediatric perspective, we want to think of this as a process and involves more than just the transfer of care. So we generally start talking, or we start thinking about this in terms of what's the difference in the model of adult care versus pediatric care. And so there are some sort of stereotypical differences that we think about. There are some structural differences in pediatric and adult care. So we tend to be, I think, as a philosophy, tend to be more provider and parent controlled. And as, again, we were talking about in the last presentation, that we want to start moving away from that with independent visits, with giving adolescents a lot more autonomy and things like that. But as pediatricians, by nature, we are used to that. We're dealing with babies, infants, and toddlers a lot. And so we are, tend to be more paternalistic. Whereas on the adult side, the patient does tend to be more responsible, and they tend to be more reactive. I mean, I think the more common, concept on the adult side is, oh, how can I help you today? What can I do for you? And the patient is responsible for sort of bringing a lot of that up. Structurally speaking, we in pediatrics, while we might not think we do, we tend to have more case management and social work support. And we tend to have more multidisciplinary clinics. And if you think of our tertiary care institutions that handle some of these medically complex patients, such as spina bifida, where you can see a physiatrist, an orthopedist, a PM&R doctor, and a neurosurgeon all in one clinic, along with a dietitian, for example. Whereas on the adult side, these are popping up, but still not as much so as on the pediatric side. So on the adult side, we are thinking of having multiple specialists, maybe in multiple locations even. Not ideal, but it happens. And patients are going to be responsible for coordinating a lot of those visits. And yes, they do have less social work and case management assistants than the pediatric sides tend to have. And, we tend to think of ourselves as supporting families through the process. Obviously, there's adult changes. Patient must be proactive. Obviously, this translates over. I know a lot of us, many of us on this call are probably pediatricians. And I know we tend to think of ourselves as, we're warm and fuzzy, and the adult side is a little bit more colder. And stereotypically, this tends to be the case. However, I will say, in our experience, we've had a lot of patients who transferred over to the adult side and have come back, and we get them. We used to run a life skills program where, the adult patients would come back and talk to our pediatric patients about what it was like, and they loved it. They loved the fact that the adult providers listened to them, they loved the fact that the adult providers talked to them about, what's your opinion? What do you think that you should do? Here's my advice, take it or leave it. And I think, it alludes to, again, what we'll talk about more in this presentation and also in the last one, where the more autonomy and the more engagement that the young adult has, and the more we encourage that on the pediatric side, the more success and the happier our patients are going to be on the adult side and that model of care. So again, we've had a lot of adults come back saying how much they love the adult side, and how much they did not like, as they got older, our pediatric model of, telling them what to do, talking to their parents more, all that kind of stuff. So a lot of benefits.
Yeah, and I would say it's all in the way we frame it. So it's a culture change, and it's going to be different, not better or worse, just different. And it's important how we frame it, right? So it's scary enough to go to a new provider, especially if you've been in pediatrics for a long time. A lot of people think of, I know us at Lurie Children's, almost like family. And so it's scary enough to sit down in front of a new adult provider and have to explain your medical conditions all over again and start fresh. So it's really important to frame it as different, but almost as try to be, this is exciting, almost like a graduation, right? It's scary enough. So how we frame it, I think, does make a difference. And so getting young people ready and making them their best advocates for themselves is really important, because it is a real culture change between pediatric and adult, not better or worse, different. Yeah.
Exactly. And so let's start talking about some of the barriers we talked about. And again, in the last presentation, it is true. I don't have that on here because it didn't come out on these studies that I looked up. However, it is true that we tend to think, of adolescents as, barriers, or family compliance as barriers and things like that. But it is us that might have to adapt to that a little bit. We break this up from different stakeholders here: pediatric providers, adult providers, and families and patients. I think we as pediatricians tend to think that there are not adult physicians who have knowledge of these pediatric conditions. And that may be true. It is changing, but it is true. I don't know if I think I have a slide coming up later that talks about adult resident comfort level with certain pediatric conditions. And it is lower than you would think. And historically, we all know this is because our patients, our pediatric patients, have not survived with some of these complex medical conditions into adulthood in the past. And now they are. So naturally, you would not have adult physicians who would not have knowledge of these. I think, we tend to think of, in practice, we think of reimbursement and time as the same thing. So time and reimbursement to do all these things that we're going to talk about throughout this presentation, all these things that we talk about in the transition to adult care, the tasks and the role and the time we have to spend. And then our own reluctance. I think we tend to think that we have provided great care for these patients, and we like them. We like our patients. We like our families, and we're like, oh my God, it's so much fun seeing you. It's nice. It's great having this relationship. I don't want to let you go. Adult providers also report that lack of training. Exactly that. So none of this is a big secret. Difficulty meeting psychosocial needs. This is one of the more common things that we see, especially when we go to like tertiary care hospitals in some of our partner tertiary care hospitals, and alludes back to the lack of case management and social work support in some of these adult settings. Lack of time and reimbursement is always there. I highlight the lack of coordinated transfer from pediatric practices because, again, this is something we can do something about. A lot of the other things are system level issues that, of course, need advocacy and things like that to be changed. But this coordinated transfer, thinking of how you make the handoff, how the information exchange gets there, all those kinds of things. And we'll talk about that as this presentation goes by. But that's something we can actually do something about. Families and patients have reported, I think, what everybody would imagine they report, which is, yeah, there's a big difference in the adult side there. And, I'm kind of nervous. I mean, like Angela just said, Lurie Children's like family, or whatever pediatric your practice is like family. I've been going to you all my life. You know everything about me. It's great. But now I have to go explain it all over again. And again, if you can imagine families, parents, or children with complex illnesses, this becomes, this is obviously something they would be concerned about. So when we look at the literature and what has been shown about transition in general, there are a few different. A lot of the literature, very surprisingly enough, has been condition specific. And as you see, and this will play a role later on, I'll make a comment about this later on, about where condition specific, things come into play. But there are some generalities, of course, in transition to adult care. People have really looked at planning for transition. As you can see, the article I pulled this from the right kind of divides it up into transfer assistance, planning for transition, and then really, incorporating adult care into your pediatric setting. A lot of people have done planning for transition. This is things like transfer checklists, which we'll get into later, transition readiness checklists, things like that. Transfer assistance, people have things like medical summaries and stuff like that. But there are a lot of variations and interventions and outcomes, and I'll talk, I think, more about this in a second. Again, a lot of these are very condition specific. Diabetes, I know congenital heart is lower on this list, but somehow when I look through the literature, I do happen to find a lot more in congenital heart than what's out there now. But certainly diabetes is a big one out there. So we're going to start in a sec. We'll get back into some of the review literature in a minute. But I want to throw out there a framework to look at transition to adult care. And this is, again, meant to be a framework. It's probably, academically speaking, one of the leading frameworks. And many of you out there who have taken any steps towards transition might have heard about this and might have seen this somewhere. It's published by a group called Got Transition. It's supported by I think the National Alliance of Adolescent Health. And again, if you're applying for a grant, if you're looking at a research paper, or if you're doing something academic in the world of transition, this tends to be a very leading framework that people will use. And we're going to go through these steps in a second. It is one of our learning objectives to just kind of be able to think about this framework. That being said, I will throw out there, and I think I'll throw out there with some element of confidence, certain aspects of this are evidence-based, but the entire thing is a very nice framework. I wouldn't be afraid to deviate from it, and certainly Angela and I do deviate from it when we do our divisional consultations and when we do our even our patient consultations. But it really talks about, this is really very, kind of how to build things in your office or in a program. And again, the rest, this might be more apropos to people who are thinking about this from their office or program standpoint. So the first step is really.
I was just going to say, and certainly there are other models used in Europe. I know when we've been in conferences, and Parag's been in conferences internationally, there are also different models that are used. This is the prevailing model here in the US, but there are other simplified models I know that they use in Europe. There's one called
Ready, Set, Go.
Yeah, that kind of like makes it a little simpler. But when we get farther on in the presentation, I know when you're in a busy clinic setting, breaking things down into 6 core elements, and even when you're building out an entire infrastructure potentially in your practice, can seem kind of overwhelming. And Graph Transition's phenomenal, and it gives you a lot of tools on their website, but it can be a lot. So, when we talk about building infrastructure for transition and helping your patients, it doesn't have to be complicated. It can be simple. And what we do know from research is doing something for transition is better than doing nothing to really help your patients a lot. So it really is great to have a framework and have some research and have some best practices to go off of. But to know that this isn't necessarily the Bible that you have to follow really strictly, it is really good to have some things to start with and to go off of. But to know that there are other models available, certainly. And I know obviously this organization, the Illinois chapter of the American Academy of Pediatrics, has some phenomenal things available that I think we'll probably touch on later as well with their work with the Division of Specialized Care for Children as well.
Yes, and later on in the presentation, we will talk about building a transition program, and it does simplify this quite a bit. Mm-hmm. But for now, this is actually a part we don't actually simplify, which is having this transition guideline or policy. Policy is a very challenging word in some places, meaning, do you have to adhere to this? We use guidelines sometimes. The main thing about this is that you want something that's going to just introduce the concept of transition to younger aged folks. Some of the data does show out that if you talk about this, I know the AAP recommends 12 to 14. I think most of our providers feel more comfortable more between the ages of 14 to 16. And that's true nationally too. A guideline doesn't have to lock you into an age. And I think, again, as we heard in the last presentation, adolescence is a journey. It's not, at the age of 18, all of a sudden you have this capability to be an adult. And so we know that even in pediatric offices and with varying developmental stages, people are going to transition at different ages, along with life circumstances and things like that. People are going to transition at different ages or transfer to adult care at different ages. So this should be more of a guideline saying you are going to transfer care, and that's a good thing. We're going to help you through it. And this is what you can expect over the next few years as we go through this process. So it's really meant to introduce that concept. Prior to this, what was happening was a lot of people would hit the age of 17, 18, 19, 20, 21, and they would be talked about transferring care for the first time. And they were like, oh my God, that's right. I never really thought about that. Oh no, it comes as a shock. This is sort of to ease that shock a little bit. But it's more to communicate the office practice, the office philosophy, be a little bit supportive, leave a little bit of that variation in terms of people's life circumstances and maybe some developmental stages and all that kind of stuff. And so there are ways to write this up. And there's a lot of examples on GOT Transition and a lot of other places. Step 2 is kind of developing a system in your office to track and monitor the patients. So this includes everything from tracking transition readiness to having provider checklists on are you doing everything you need to do at each visit, having a registry maybe of your most complex patients. We know that 80% of patients in most pediatric offices are going to make this transfer of care without a lot of need for specialty care and all that kind of stuff that you have to coordinate. But there are 20% that are going to take a little bit more work to try and figure that out. So things like that. Step 3 is what a lot of people tend to focus on, and it's very important, don't get me wrong. But it tends to be the focus on a lot of it, which is really doing that transition readiness for our patients and families. It's also very, it is one of the more time-consuming ones. This is just a sample list of things that people might need, that you might want to include on a transition readiness checklist. This really falls under the category of assessing transition readiness. Just to give you an example, so I will actually throw out my own little tidbit on this. I work a lot with medically complex families, with kids, more than 5 specialists, technology-dependent trach vent patients like that. I tend to find, even at my hospitalist work and in our transition clinic, linking conditions, medications, and providers when you help families organize their care does work out pretty well. Meaning, if you have a medication, there should be a condition linked to it. There should be a provider who's responsible for that medication, and there should be a provider following each of your conditions. Even if the default's over to the primary care practitioner, that's fine. But it helps families really understand and organize their conditions a little well. But all these other things on there are great. There are a lot of checklists that exist out there. The one on the right there, or on your left, the one that's color-coded, is the Illinois chapter one that's been developed a long time ago. It actually has a nice column for not applicable, meaning somebody will always have to do this for me also. And it has a column for not applicable. It also has the purple, yellow, and green that you see on the screen are developmental stages. So it's actually a very robust and a nice checklist that kind of exists on there. The one on the left was that one that we very quickly incorporated into Epic under using the doc flow sheet functionality in Epic. And it serves as both a checklist that we would administer to patients, that provider administered to patients, meaning I'm assessing their readiness. Also, it serves as a checklist for myself as I run through those questions and be like, oh my God, I got to do this, I got to do this, I got to do this. One of the more famous ones that you'll see out there that's more academically studied is called the TRACK. They're up to TRACK, I think 5.0 right now. It's called the Transition Readiness Assessment Questionnaire. If you look at research papers or if you're in the academic world on this, this is probably the most prominent out there. It's not, I think they made it 20 questions now. I think it's up to 20 or so. They internally validated it very nicely into these 5 domains. And again, it's incorporated into some EMRs. We've got it incorporated into Epic. We've got a lot of people that send it out via MyChart, for example, to patients. And it's intended to be patient filled out and provider reviewed. So you as a provider would get it back, you'd review it at an adolescent visit, and you'd address the things that maybe the adolescent wants to learn and things like that. I think one of the trickiest things, and we'll get into this when we're building a program, is making sure you have the time and the resources to actually address questions that show up here as no. And that becomes a little bit challenging and tricky. We came up with a list of things that what you can do. These are quick things that you can do in your office. You're seeing somebody and you're like, hey, are you ready for transition? I want to get a quick feel for the things you want to think about. A group at Blurview, the rehab center in Canada, actually developed this, and it seems to have caught on a little bit, is having their patient describe their illness. And it doesn't have to be their entire illness. You can do this by condition or whatever in about 3 sentences. It tends to avoid like the one-word answer, like, I got something wrong with my kidneys, or it tends to avoid like a biochemical dissertation on their condition. Having them learn about their medical history from their parents, a lot of our patients have had chronic illnesses since the NICU. And we find that those patients don't know as much about their NICU history versus adolescents who have acquired illnesses, who tend to, this isn't data driven, this is our anecdotal experience, who tend to be, more engaged and more involved and knowledgeable about everything that's kind of happened. So making sure that some of our adolescents remember, ask your parents about what happened to you when you were a child, and ask your parents about your family history, for example. That's things that we don't think about a lot in pediatrics, but obviously in the adult world, it's important. Having them create a portable medical record, and there's some templates that exist out there. Some families are into this, some people are into this, and it helps them the process of doing it helps them organize. And of course, when they go to the emergency room or they go to somewhere, they have it in front of them. Have them go to the front desk to make the next appointment. Say, you go now, you go make your next appointment. It is surprising, even to us who've been doing this for so many years. Like I used to say, we ran this life skills program, and we would bring these adolescents through. We have different stations, making an appointment. We'd have somebody mocking it on the other side, and we'd have somebody, they'd go down to the pharmacy, we'd give them fake prescriptions, and they'd hand it to the pharmacist, and the pharmacist would ask them a bunch of questions about themselves, and then they would give them the bottle and say, okay, this is that. And it was nice to see, but also a little bit surprising how some of these 16, 17, 18-year-olds were shocked at their ability to do this and how much fun and how pleased they were at, like, oh wow, that was cool, I was able to do this, And in complete disclosure, I was sitting there thinking, wow, that wasn't that big of a deal. But yes, it is. It's like was said in the last presentation, we don't remember our journey in adolescence, a lot of us. And I think the older we are, the more we forget how, when I was an adolescent, I probably wasn't able to do adult things, and it was kind of cool to do adult things. Nowadays, I have to say, the last time we brought this up, everybody was like, what do you mean fill a prescription? I just refill it on my app. So I think I have to adapt a little bit. We have to adapt a little bit to how it's being done nowadays.
And I would add one thing that I wish I really never would have to say, but in this age where we were just hit with a cyber attack, and Ascension was our colleagues at Ascension were recently just targeted. I would tell all of our adolescents, to go old school paper and pen, right? Too, like have a notebook, write down questions, write down medical history kind of things also, because if you are dependent on going into your MyChart for your entire medical history, and what if you can't get into MyChart? Because unfortunately that happened to our patients for almost 6 weeks. So I would love to say that's never going to happen again, but what if it does, right? So you should have a backup to that. And actually a lot of our medically complex families, and I think maybe some of you have families like this, had binders at home, and they had everything, all their kids' stuff in those binders, and like they were okay because they had everything written down, and they had all their kids' medicines, and we all have families like that probably that we've helped take care of. So I hate to say it, but I think that there is still a lot of efficacy into having like write your questions down, have like a paper backup to things, because unfortunately I can't say that these things might not happen again. And I think it's a good exercise for young adults and adolescents to, have that as a way for them to learning some of this stuff about themselves, and to write these things down for themselves. But it obviously, or have a note on their phone, like in their notes section of their phone, obviously have them leverage technology as much as they can, their Walgreens app or another app on their phone to fill their prescriptions. They need to do things in the way that they find comfortable, which is a lot through technology, but also have an understanding that sometimes technology can fail us, like with our unfortunate cyber events that have happened lately. Just a note that I wish I would have never had to say, but unfortunately had to.
Exactly. So yeah, there are a lot of ways, and this is a perfect example of having patients prepare some questions. Nowadays, with people with their phones on them, we think of questions as we walk out of the office, most likely, or in some random day in our life, we can't think of the questions when you're sitting in front of your provider. And so, we say, yeah, I've always had your phone on it. Just, make a list of questions you want to ask the next visit. And, we think of this, and, we think of meeting alone with adolescents to talk about sensitive topics and things like that. However, when we did our life skills program again, and we asked our adolescents, like, what are you most worried about in terms of talking to your providers? And they said, making a mistake. So they're worried about saying something wrong. And I think we want to, in practice makes perfect, right? And so we want to give our adolescents a lot of confidence that, one, you're not going to make a mistake. You're talking about things that you're feeling. It's not there's nothing that is a mistake. You explain it the best you can, but you want to give them practice, and you want to give them confidence in explaining everything from headaches to like stomach pains to their medical history, not necessarily about sensitive topics, and just giving them that confidence to be able to do it even while their parents are not in the room. So we do encourage that, not just for sensitive topics, but also just to have them, get that feeling of being in there and not being afraid of making a mistake. And asking questions is a great way. Having a list of questions is a great way to kind of ease into that. So just to bring everybody back to the framework that we're in, we're still talking about these 6 core elements. And that was, core element number 3 is sort of transition preparation and transition readiness. Step 4 is kind of having a transition care plan. And this is a template that we use, Angela and I use in our transition clinic. This is by no means a data-driven template, nor is it a, something that's out there in the world, but it's worked well for us for over 10 years. And so we do talk about knowledge and skills. Most of the patients we happen to see in our clinic happen to have a severe level of intellectual disability or some kind of technology dependence. And so, it does default, the knowledge and skills defaults to the caregiver, whoever that might be. So we want to make sure they know their conditions, their medications, their providers, and the skills and things like that. We do start with an adult care plan. We'll talk a little bit more about this in a minute, but we focus on the primary care. As pediatricians, I think a lot of us, and I don't know how many specialists are on the line, but in general, I'm a primary care provider as a hospitalist. And so we focus on strong coordinated primary care. We happen to the University of Illinois, and I was one of the hosters of this. And so we tend to use med-peds programs because we see these complex patients. But it's not necessarily the case. We also use our FQHC partners, and we use other practices that are around. We use our tertiary care institutions, but a lot of their extended practice networks, actually. We use them quite a bit. And we just want to find a good fit for primary care. And then we do ask, and we'll talk about this again more in a second, but we talk to the primary care doctors, and we like to meet them first about, do they have access to the specialist that this child might need? And do they have the capabilities of caring for them in terms of everything from, does the office have enough space, things like that. And then we do go through each of the specialties that the child is seeing. We hope that we can actually eliminate some specialties. And I don't mean that in a bad way. I mean that in a very good way, in a sense that we tend to do a lot of monitoring in pediatric care. And we find in adult care, a lot of times it's specialty referral as needed, if needed. And so we talk to our families about that difference in culture sometimes, that maybe they won't get an MRI every 6 months or an ultrasound every 6 months to a year. And they won't necessarily need to see this specialist, but it will be available to them if needed. And your primary care doctor can certainly make that referral. We try, and the other reason we look at these specialists is we want to make sure that there is nothing acute going on. So if there's a planned surgery, or if somebody's weaning a medication, or if somebody has a plan to, really start a new treatment line that's going to last about 6 months or something like that, in any of these specialty care, that's necessarily not the best time to transition. And so we do make this list. We want families to know what they have to do. Sometimes there is a quaternary care that we have. So if somebody has a heart transplant, or if somebody has, a quaternary care condition that really needs to go with certain institutions, we will look in that institution. We will actually organize the primary care around that institution. So again, most of the time we're thinking about primary care, and again, we'll talk about this more in a minute. But sometimes we are looking at what the primary specialty care that this patient needs is going to be, and then we build off of that. But just to get through this transition care plan, the next step, we as a pediatric institution believe, and we've done surveys of our institution, and we all believe this, is that we should be addressing things like education, vocation, living, insurance and benefits, and guardianship, and any other future needs that these patients might have. We all tend to believe, I think, as physicians, that we're going to take care of their health and that's going to make them more successful in life. But I think we all know deeply and internally that if they have other things, if these adolescents have a plan in life and they have, we help them finding resources with all of these things, that they're going to actually take care of their health better, naturally. And somebody brought up this great analogy on a podcast I was on the other day, it's like athletes. Athletes don't take care of their health. It's not that they want to take care of their health and they happen to then, do well in sports. It's because they actually want to participate in sports that they take care of their health better. So that same analogy I thought worked really well here. And again, I'm blessed to do this with Angela, and I know a lot of people who's a social worker by training and has a lot of expertise in this. But I know a lot of people on the calls don't have that in their institutions or in their offices. And so I think, we do actually have a few slides coming up later that talks about some of this stuff, but it is best to get to know your own local resources that exist and what goes on on a certain level, not necessarily on the level of a social worker, but at a certain level, it really will help your family. So, as best you can, I think it definitely helps. And I think most of you all probably do too. That was sort of step 4, is making that transfer of care, the transition of care plan. Step 5 is really the transfer of care, the actual process that most of us, many of you think of as transition is, how am I going to get this patient to the adult provider? And so you want to make this an engaging process, certainly. There were some surveys on what do adult providers want, written summaries, speaking to providers, and some educational info about these conditions. This is where portable medical records that we talked about earlier, having your families create, really does help. And, some of these were taken from before, Epic has their portable medical summary. They have a summary page on there that you can do. We created a while ago. We don't use it as much, but we did create a report from Epic that pulls in all the fields that we kind of want. And so leveraging the EMR to kind of do this. But of course, we all know kind of garbage in, garbage out. So if you don't update that summary page with the problem list and the medications and the vaccinations and all that kind of stuff, it's not going to go well in the portable medical record. And it's going to be a big data dump over to the adult side, which tends to be a little bit worse. So these are just examples of templates that existed out there. We'll talk a little bit more about this transfer of care as we talk about building a program and developing your relationships with adult providers. But just kind of getting through these 6 core elements, core element number 6 is kind of continuing to be a resource. And we'll talk a little bit more about what this means later. But in general, it means being there for your patient, possibly, and for your adult providers who might want to call you back to ask you a question, giving them your contact information, sending it along with maybe the medical summary and the handoff so that the adult provider can call you with anything. And this applies to specialty care, probably even more so than primary care, because a lot of adult specialists might have some questions and things like that. So definitely making sure that the adult provider knows who they can contact if they have a challenging question that they might need for this young adult coming over to their practice. So getting back to the data a little bit, I pulled a few reviews, and again, I know the dates on these are a little bit old, but the themes have not changed over a few years. The main thing I want to focus on in some of these reviews that exist out there on transition is really there are a lot of different interventions being done, and there are a lot of outcomes that exist out there. Unfortunately, in our field, and we do a lot of research, I co-lead the special interest group that we just presented at the Pediatric Academic Societies, and I'm an administrative member of our National Research Consortium, so we keep up with this stuff somewhat well. We're still looking at defining what are the most important outcomes to study, and to study in a more massive kind of way with standardized interventions. Right now, the literature, if you can imagine, is still in the phase of doing really nice local small interventions, measuring the outcomes that maybe are some process outcomes or some outcomes that occur later, and not really being able to have grander statements about what happens or not. A good example is those 6 core elements we just talked about and those transition readiness assessments. It has been very challenging from a research perspective to link transition readiness scores with good adult outcomes, or even with simply making that first adult appointment, certainly with having good clinical outcomes or having a better quality of life, for example, as an adult. That linkage has been very elusive and challenging to make. And so by no means do I want people to walk out of here thinking, oh my God, I got to do transition readiness assessments and my kids score well, this is going to go great to the adult side. That's not really the way it works. It's more simply that we think that transition readiness assessments are commonsensically a good way to go. And they're probably linked to something good on the adult side. What I will say from some of these articles that are out there was that what it seems to sum up to be is that some formality to a program does seem to work. Some of the more data-driven aspects that seem to work, at least to positive outcomes that we would think would be great, was having that guideline or policy and giving the name or some, at least a clinic number, making a personalized referral to an adult care center or an adult care practice. Has a positive outcome. If you imagine, people are more likely to follow through. They know you. They trust you as a pediatrician. They're more likely to follow through if you say, you know what, I think this provider is great or this clinic is great for you. Give them a call and set up an appointment there when you're going to the adult side. Rather than, hey, go find an adult provider. Good luck. Let me know when you find them. I'm happy to do a warm handoff, but let me know. It works out better when you give that that referral, and having that guideline out there does seem to ease the patient experience into transition. And like we were talking about, I think this is a repeat of what I was talking about earlier, which is there's such a variety of interventions, and some of the interventions, just to throw them out there to give people ideas on things that they can do in their clinic. Having transition navigators, having care coordinators, leveraging technology, text messaging reminders for appointments and things like that. Having a variety of apps for appointment scheduling, for medications, along with for portable medical records and things like that. Lots and lots of people have done educational interventions. That's probably one of the more popular ones. People do educational days where they talk about some of the adult skills that you might need to know. That's what we did, for example. Divisions have taken this on really well, and they've done a lot of this in terms of, cardiology day. Let's learn about your heart condition, spina bifida day, and things like that. So as you can imagine, there are a variety of interventions to address a variety of those 6 core elements that exist out there. This is what I forgot I had this slide in here. But a structured format, meeting adult providers or having some sort of referral to a specified adult provider is nicely data driven. And again, the inconsistencies in the literature that makes it hard to sort of recommend a lot of blanket stuff is this incomplete details of the interventions people are doing, the outcomes that they're measuring, and the disease specific focus that doesn't tend to carry over. So example of diabetes measures hemoglobin A1C. It's not that all conditions have a very nice clinical marker that you can hang your hat on to really measure. So I wanted to give that as an overview of sort of the 6 core elements and take a quick look at our time check here. I think we're kind of doing okay since we're a little bit ahead, if that's okay. Talk about some specific issues that came up even in the previous presentation. Guardianship is one thing. And I'll let you do the second slide, but I want to do this one just for a second, just to stress to the physicians that are out there. This is an issue that somebody asked a question about at the last one, and I'm going to go. Angela will go through the process in a second, if that's okay. But at 18 years, the way this works is that the child becomes a legal adult, and we all know this. This is why guardianship specifically tends to be an issue. And to start this off, I want to talk about, we definitely think of this as a spectrum. I don't know if people can see my fingers. But this is definitely it's on a continuum of shared decision-making and what we want. And we always try and lean towards the least restrictive shared decision-making option. So if you imagine all the way on one side is simply good communication with your parents. You're 19 years old, you're an adult, everything is legal for you, but there's nothing wrong with having a trusted adult in your life that you can run stuff by, that you can, ask for advice. We all do this. So that is a form of shared decision-making. It's the least restrictive one. And it's one that we encourage for almost everybody. And it's the default for almost everybody around. Guardianship, what we're going to talk about here, is actually the most restrictive. On the other end, which is at 18, you're becoming a legal adult. It is a court process that is essentially, in a very harsh way, it sounds like you're taking away the rights of somebody else, and you are. But obviously, we are doing it under the idea that this young adult does not have the capabilities to make decisions, to understand certain decisions. And we're doing it to protect them so they don't get taken advantage of in a lot of different ways. There are different types of guardianship, and in the middle, we probably don't have to get into all of it now, but in the middle are things like power of attorney, limited guardianships, and the new Illinois one. I'm blanking on the name of it.
Shared decision making.
It's called literally shared decision making. Fall in the spectrum in the middle. I don't think we have to go through all the details for the purposes of this presentation of each one of them. Know that we should think about the least restrictive one. Guardianship is an option, certainly for our most intellectually disabled patients who are at risk for taking advantage of it. This is a court process. It is something that unfortunately requires a court because you are taking away the rights of what's guaranteed at the age of 18. And there is a physician part of it. And as soon as I go through this physician thing, I'll turn it over to Angela to describe a little bit more of the process because somebody asked about it on the last presentation. But there is a physician form. So this may come across your desk. This is the form that we as physicians have to fill out. It is a Cook County form. These are all county-driven processes. What?
It's county-based in the state of
Exactly. It's county-based in the state of Illinois. This is the form. Most counties in Illinois have a very similar form, if not exactly the same one. The one that trips most of us up as physicians, if any of you on there are like, oh my God, these legal forms always make us a little bit nervous. Question 1 and 2 are really about the diagnosis. All they're looking for is, what is the diagnosis that makes it so that this patient has this intellectual disability and can't make these decisions. And you want to list a diagnosis, whether it be autism spectrum disorder, whether it be a chromosomal disorder, a genetic disorder, or some element of cerebral palsy, or whatever it might be. Put it down on there. Question 2 just describes kind of maybe if you have some data, if you have school IEP forms, if you have anything that IQ testing, anything that you might have that puts it on there. Question 3 is really the one that I think is trips a lot of us up. And the one I pay the most attention to, which is the respondent totally or partially incapable of making personal or financial decisions? And I don't know, as a pediatrician, most of us are, and Angela and I are seeing this patient for the first time, and even many of you that have relationships with the patients, if you're thinking about patients that are not necessarily very intellectually disabled and certainly not completely developmentally appropriate, they're somewhere in the middle, somebody who's high functioning with cerebral palsy or intellectual disability or something like that, you're like, I don't know if this person can, manage their money, or I can't give you a list of exactly what they can and can't do. It's not something that we're used to doing as physicians. Unfortunately, there is not an objective tool that helps you figure this out. Not one that we could find in the last 4 or 5 years when we looked around. The closest thing that our neuropsych department or anybody could help us out with was a form called the ABAS-3. It's the Adaptive Behavior and Assessment Scale. And it's a functional one that's filled out by the families. And we have had families fill it out every once in a while when there's like a question about it, to help us kind of, use a score to help us decide, whether we should think about total or partial guardianship. But it's not something we use very commonly. Most of the time we are using subjective questions, such as, do they do their activities of daily living by themselves? Can they use a microwave? Would you trust them like cooking on a stove? Would you trust them staying home alone overnight ever by themselves? Can they go to a store and can they count change? Do they take public transportation? And things like that. And if the answers to all these questions are like, oh no, oh no, oh no, oh no, they can't do that, I think you get a pretty good idea about this person probably needs some sort of total number, number 3. Partial guardianships do exist. Our legal colleagues and our medical legal partnership colleagues that Angela and I work with say that the state of Illinois doesn't look so favorably on partially for obvious reasons. They're like, well, why can they do this and not that? But we have done it. We have done it. I think marriage, driver's licenses, things like that do fall into these categories that people might want a partial guardianship on. But mainly we're thinking about, educational, vocational decisions, healthcare decisions, and financial decisions. Largely, they fall into those 3 categories when you're thinking about total guardianship. But it is a subjective assessment. These are some of the questions we use. The ABAS-3 is an example of a objective one that you could use. Certainly most families we work with will have legal lawyers. You can do this without a lawyer, and I'm going to turn it over to you and Angela in a second. You can use a lawyer. You don't have to, but most of ours do. And the lawyers will look over these statements to make sure that what you write will be consistent with what the family actually wants to achieve in court. So in this case, we use our legal friends as partners. Go ahead, Angela. I'll turn it over to you if you have anything more to say, or maybe a little bit. Somebody did ask about the process in the last one, so maybe reviewing that.
Sure. So yeah, what we're discussing is, adult guardianship, or what you'll hear the term plenary or full guardianship of the person. There's also guardianship of the estate, which is different, which is over financial matters, right? And you can do guardianship on your own. You don't need a lawyer. For a limited guardianship, you will actually need to go into court for a lawyer, because with a limited guardianship, you are carving out rights that the young person will retain to make for themselves, and a set of rights that the guardian will retain to make. So for that, you will actually need a lawyer. Again, we are not lawyers. We work a lot with legal partners, but we deal quite a bit with guardianship questions from across our medical organization. We are like the people everybody kind of calls when they've got a question about guardianship or about shared decision making. So shared decision making is an alternative to guardianship, and I counsel folks that really all alternatives to guardianship should be considered before guardianship, because guardianship is the most we're pretty conservative because you are talking about taking the rights of a person absolutely and completely. Can an adult guardianship be reversed? Very technically, yes. It is very hard. It's hard to do because you're basically going back into court and say, oh yes, this person is now competent. Guardianship isn't because you have an 18-year-old who's just making some bad decisions. Lots of 18-year-olds make not so great decisions, right? Because we know the prefrontal cortex isn't completely developed until about 25, right? So 18 to 25 is a really rich developmental stage for our patients and our families. We're talking about young people who will never be able to make full decisions for themselves because of a medical or neurocognitive diagnosis or injury ever, right? They're not able to appreciate consequence or enter into contract. That's what this guardianship is about. We have young people who might have autism or might be highly functioning and they're still developing that ability, but they may not necessarily need a guardianship. Maybe they need a healthcare power of attorney. Maybe they need shared decision-making. And again, I'm going to give you guys a website that's going to be really helpful to everybody because it will give you all the information on healthcare power of attorney, shared decision-making, and guardianship. It has the guardianship health handbook on it. It has information on the state guardian of the state of Illinois on it. And I can put that into the chat, but it is the Illinois Guardianship and Advocacy Commission. So, but what folks really do need to understand is the report of physician in the guardianship situation is by county in the state of Illinois. The report of physician is the only piece of evidence in a guardianship case. So the court really does rely on us, you guys, the physicians, to look at this form about the decisions they're making. The young person has to be in court. So this is not done like without the young person's assent, really, okay? The young person has to be served with papers. This is important. This is, you know, a real court, you know, proceeding in terms of sometimes, I know during COVID, it was being done by Zoom. I think in some cases, at least in Cook County, I think it still might be done via Zoom. On the GAC website, I think it also has some legal resources for folks in Cook County. There is a what they call a pro se or do-it-yourself desk in the Daily Center, where folks who want to do this themselves can get help from a legal aid association. All that information is going to be on the GAC website. And our contact information, I think, is going to be somewhere. If folks need any help with this, they can reach out to me. I've got some legal colleagues that we work with that do sliding scale adult guardianship that we refer all our patients to. I know because the paperwork for guardianship is pretty overwhelming. So were there any other specific questions people had from the previous sessions, Parag, that I did not touch on?
No. I think they'll put them in the chat and we have the panel afterwards, right? So okay, I think we can, I'm actually, yeah, just for time's sake, I'm going to skip over the health insurance stuff and we can talk about it in the panel we're on, because I want to get into, you know, sort of the nuts and bolts a little bit about the last part of this is going to be the nuts and bolts about how you would go about maybe building a program and some of the tools and resources in your office or in a division at a hospital or however you want. Because Angela and I do this quite a bit. So the first thing we always talk about is really getting the data. So if you're in an office or in a division or in a program, you know, you want to know who your kids are, how many are in the pipeline, and how many kids we're talking about. And so that's the first thing we really talk about. We do, for Lurie Children's, for example, we always try and figure out where they come from. And I'll show you in the next couple of slides, you know, sometimes we create like a little heat map of where your population is so we know where we need to target finding adult providers and things like that. If you can, get an idea of their comorbidities, because that plays a part in transferring to adult care providers. And things like that. So, and then, you know, we want to focus on a few things. What we found the biggest flaw that people do is try and do too much at once. People are like, well, I want to make a guideline, and then I want to make sure I do all the transition readiness, and then I want to make sure I create a medical summary, and then I want to make sure I have a transition care plan, and then I want to make sure that we do a good handoff to an adult provider and things like that. It's tricky to do all of those things in we know behavior change is hard, and putting together these kinds of initiatives is hard. So we try and focus on one or two and build off of there in general. I want to make sure that, if you're working in an office, that you have a champion, or in a division for that matter, you have a champion, and then you get some input from other stakeholders, especially patients and families, but also, possibly adult providers. I think that's one of the things that even in the transition community, we sometimes forget, and we lack the involvement of adult providers and what they want and what they need, and how they would like their handoffs and things like that. And again, getting that data, how to, knowing your patients, as you all know, many of you might be in a private practice or anywhere somewhere, trying to figure out how many are in the pipeline. Insurance and zip code is a big deal, especially for folks like us who work with a large catchment area. There's multiple zip codes, and then insurance, it does, for better or for worse, plays a large factor in where our patients can go as an adult. Some sort of risk stratification is nice, given that everybody in our fields are time strapped and may not have the ability to do everything for all of our families. So knowing which ones are going to need the most help, some sort of risk stratification sometimes helps. And this is what I was talking about earlier. We try and sometimes make heat maps when we're working with divisions or institutions at large, saying, okay, this is where your patients come from. We need to definitely prime providers in some of these red zones or some of these darker zones that we hit up. And then phase two is sort of building the resources. So once you gather that data, again, we talked about having limited objectives and having some objectives that you have. So you want to build some of these things, like build a policy or guideline, have a committee that kind of works on that a little bit, build a flow sheet, build a provider checklist, a transfer of care plans, educational materials for families, educational materials for providers, adult provider lists, things like that. These are probably the top 5 or 6 things that we've built to kind of help your team, your office, your division, whatever it might be, your program, have a robust transition program. Again, this is an example of a transition policy, a guideline. We talked a little bit about this earlier, just kind of setting that tone, setting what the practice is going to do and what the practice is going to help you out, help their families out with, being a positive, supportive kind of transition. Building out dot phrases. So we took dot phrases from obviously Epic, which is one of the most popular EMRs, but most EMRs have a version of dot phrases where you can remind yourself or put in a note a common phrase that you use or a common checklist or a common set of guidelines that you want to put in an after visit summary or some sort of discharge instructions, whatever you might call it in your EMR, that you can build to help your team do this. Transition, again, the examples of patient transition readiness checklist, the examples of the transfer of care plan that we talked about earlier, adult providers, we tend to use, we see some of the most complex kids at Leary. We tend to use med-peds providers. They are very, very good at doing this. They've been, they're board certified in pediatrics and internal medicine. Most of them are very comfortable with pediatric chronic conditions. Many of them tend to work at tertiary care institutions. However, we are finding a lot in the community. Family practice is another one. My personal opinion is underutilized. We've met a lot of great family practitioners who do an incredible job at taking care of some of our most complex patients because they're, and as we know as primary care doctors, and I can speak to this as a hospitalist primary care doctor, we don't have to know everything about the conditions in a quaternary care, tertiary care kind of way. We just have to be very good at understanding it, following through, doing some good care coordination, and making some limited medical decisions based on our medical knowledge. And I think family practitioners do this very well too. But again, we tend to look at what type of provider, private versus FQHC, insurance is just a big role in this. We tend to ask our adult providers, do you have access to the specialist that this patient is going to need? And if the answer is no, that is not a good fit because we are going to rely, we don't necessarily know all of the adult specialists. I don't know every adult GI doctor in Loyola, in UIC, in Rush, or even out there in the community, nor do I know every adult cardiologist or adult neurosurgeon. But I do rely on the adult primary care doctors to have access to these specialists. And if they don't, it's not necessarily a good fit. And this is something that we hope that, it's the pre-work before you start building this transition program. You get to know your adult providers, and you get to know what kinds of patients they are able to find specialists for and what kind of patients they're not able to find specialists for. Again, a list of adult providers, we tend to make like a little note. It matches up with our heat map, matches up with our zip codes. We do believe that primary care is best local. It's convenient. It's easy to access. Specialty care people will travel for because sometimes you can't find the specialty care you need within your local area. However, for primary care, it is nice to have somebody local, somebody accessible, somebody who you feel comfortable with. So we like to find primary care close to the patient's place they live. We tend to start with geography and insurance, but we always ask about family preference. So and surprisingly enough, a lot of our families have very strong opinions on where they would want to go to see an adult provider, based on bad experiences they might have had with institutions in the past. Also based on geography and location, based on their other friends and their family members or people in their community or in their community for the illness that their child has. And things like that. Certainly our young adults who have their own, who are able to, decide this for themselves, have strong opinions too. So have a recommendation in your back pocket, but certainly be open to the family preference in that area. And then skimming over this, one of the tools, I'll give you an example of what we built for adult providers. On the left there is for Turner syndrome. We did this project with our Turner's group at Lurie Children's. To send with every patient that checklist. It's a primary care health maintenance checklist. And it happens to exist. We didn't build that. We modified it, but the list itself existed from the association. And it went really well. And this goes with the data as to what adult providers really want, that educational info. This was a health maintenance guideline for adults with Turner syndrome. If you're having trouble, a lot of foundations and organizations for condition-specific places like the Cystic Fibrosis Foundation, obviously, but other ones, some of them that you wouldn't expect. A lot of them have we've noticed through the years, have taken on ownership of this transition to adult care issue. So a lot of these are parent-run organizations. A lot of these are larger foundations. Some of them are clinically based associations and national associations also for certain conditions, neurofibromatosis, things like that have created adult checklists for health maintenance, both for the families and for providers. And so we always do this, and we tell our pediatric colleagues in these areas to, let's look around first. Let's see what's already out there by an organization, and let's try and send that with the patients. Adult providers will like it, and they'll use it, and it's, they're very comfortable if they have a checklist on what I'm supposed to do for this patient to do it. It also helps with patient education. So finally, implementing all of this, what we talk to clinics about is before clinic, we have an ability to have a registry that tells you when the next clinic appointment is for your patients. So we've had clinics that have set up like meetings right before their next clinic to see what adolescent patients are coming up, who's going to transition soon, and develop sort of a template on what to see. We tend to we're working with one group right now. They have a nurse practitioner doing their transition assessments in their transition clinic. And we've developed like 2 or 3 different templates of how the visit should go. So for example, if they're coming in and they're 14 and you're just getting started the discussion around transition, or they're coming in and they're 17 and you might want to do a lot more transition readiness building, or they're coming in and they're 21 and the provider referred them to you just because they're saying, hey, we need to transition, we need to move this patient on right now. And what's that transfer of care visit look like? So some sort of like template and flow about how those visits would go. During the clinic is when you sort of administer that template. After clinic, we definitely want to make sure there's a lot of follow-up work that happens. Somebody's going to do the handoff. Somebody's going to follow up with the family to make sure they made the appointment, things like that. We want to identify those roles and who's going to be doing that after clinic. And, I think this is one of the last slides. We'll talk about, the transfer of care process that we like to work out with our adult colleagues. So we've worked with some groups and we sort of set up sort of joint meetings with adult providers, our pediatric clinic and us just to kind of moderate the conversation. but rather working out what that transfer process is going to be. And it generally goes something like this. It's not that complicated. It's the pediatric provider will make the referral, will tell the family to go to the adult, to go to this adult provider. If the patient is really, really complex, you might identify somebody in the adult practice who's going to take an intake email or some sort of note in a secure manner to send over there, just to let them know that this complex patient is coming over. Generally, we can't send too many records until that adult practice has established a file. So once that patient makes the appointment over there, we ask them to call us back, or we stock the chart to see if they made an appointment. But if they call us back and say, yeah, I made that appointment, that's great. Then we, try and send over as concise a summary as possible. Work with your HIN departments. We've worked with ours to try and create a transfer packet that goes over. It's not easy, nor is that transfer packet perfect by any means. Or you can write a last note that works out really well, that sends a nice concise summary to the adult provider. Send any education if possible. And then when that patient finally makes that adult appointment and goes there, there should be some closure there. Do you see the patient again is a big debate in our transition world, creates sort of what we call a ping pong clinic, where they come back to you for one more visit, and then they go back to the adult provider for so you can have some kind of closure there. Or you check in by phone, or you send in that saying, hey, how'd that go? Did it go well? Great, thank you so much. Congratulations on your graduation, and you move forward there. So that's an example of a transfer process. Most of the time it revolves something like that. And then finally, we talk about sort of evaluating your own work. And this is more for those of us that are either sort of academically inclined or want to do QI in your own office or something like that. There's a lot of process outcomes that can be measured. How many patients, how many flow sheets done, how many transition care plans are measured. These are all intermediate outcomes. There is still a debate on what true outcomes should be. In fact, that was the focus of our last SIG at Pediatric Academic Societies. We went to was what are the true outcomes that we should really be focusing on. Patient experience tends to rank up there, clinical markers for those that are available and things like that. But just know that there's a lot of these that are out there. And then finally, for people, resources, this is our website. We have about, 14, 15 PDFs that are out there in English and Spanish on everything from guardianship to benefits to transition care checklists, along with how to transfer to an adult provider. Like I said, there's about 14 or 15 of them that are on the Lurie Children's publicly accessible website under Transition to Adult Care. If you just Google Lurie Children's Transition to Adult Care, this will pop up. We also happen to have on our website a whole bunch of videos, webinars that we did. We converted that life skills program that I keep mentioning to videos to make it more accessible to people also during the pandemic. Everything from guardianship to benefits, educational vocational programs.
Yeah, there's a whole webinar library on the website, and they're in English, and we weren't able to get them audio into Spanish, but the PowerPoints right under the videos are translated into Spanish. So there's a link right under the videos where the PowerPoints are translated into Spanish. So we try as much as possible to get all of our content in Spanish as well. So there's 13 handouts in English and Spanish, and all of our webinar content on a whole range of transition material. So please go to our website and make use of any and all of the information on there.
And patients, obviously, the PDFs are, both of these things are patient and provider geared. Somehow we got lucky and we made it so that it works for both. I think we've had a lot of professionals look at these things, and we've also had a lot of patients look at them. And most of the time, it's all positive reviews. Got Transition is the website that is the organization that creates those 6 core elements. They also have a ton of resources on their website. All these tools that we just talked about, they've got templates for almost all of them on their website. So no need to recreate the wheel. They are all on there. And then, there's we can skip over some of this stuff just because I think we're running a little late on time.
The Illinois, that checklist that Parag showed from the Illinois Academy, the AAP checklist, that was at the Division of Specialized Care for Children. They have a great transition toolkit on their website. So DSCC has a fantastic transition toolkit on their website under resources. It is extensive. And it is very, very helpful. So all of that material is on DSCC's website.
Right, exactly. So things to remember. I mean, again, there's a lot of stuff that we threw out at you there. Just it's a purposeful process. I think that's one of the main things that we really want to embed in people's minds. It's not just the transfer of care. You want to introduce the concept. You want to get adolescents ready, and then you want to have some sort of an organized transfer of care process such that patients aren't being lost too much. Having some sort of structure to that definitely leads to better outcomes. And then starting early, making sure that this doesn't creep up on families. I think that improves the patient experience. Probably one of the few things that that really lays out there is improving patient experience through this whole transition process is notifying them early about this concept that they will transition and we're here to help you. Here's our contact information, and I know we can either. I'll turn it back over to Dr. Latimer and Dr. Caskey to see if questions. We're happy to take questions or go in the panel or whatever it is that you all want to do.
Thank you.
Thank you so much. Thank you everybody for listening. Thank you guys so much.
Thank you. Thank you, Dr. Shaw and Angela Berger, for continuing the transition of really providing an excellent presentation. That was super informative. I'm just going to start with the Q&A. So there's 2 questions, and then I'm going to open it up to the panel, open the panel where we can ask questions of all of the speakers. So thank you so much for your time. That was excellent and super informative. So the first question is, and I think you alluded to this, Dr. Shaw, is how do we transfer care for young adults who don't want to leave? They keep on coming back.
I see the question on there. Yes, and that's why I was smiling. So in a nutshell, I don't have a good answer for you. I really don't. I mean, I recently in these conferences we went through, that was our data we presented, and our success rate from our transition clinic, our very transition specific clinic, was, and by success rate, I mean, it was lower than you'd expect it to be. It was somewhere around, 50 to 75%. In the sense that, like, we looked 6 months later to see, which patients have actually kind of made it over. And most of it was due to, some of it was due to insurance, some of it was due to, lots of other varying factors, but a lot of it was due to, some kind of loss to follow up or inability to make that appointment. And it's just Angela and I to do this whole transition program, everything you see there. So we don't yet have the ability to really have a very formalized check-in process. So the one thing I would say is the data around giving a personalized referral might help, right? So if you have adult providers, that's where some data is, that's where the research and the literature might play a role in this. Is you give somebody a name or you give somebody somewhere to go, they're more likely to probably make that appointment. We are very comfortable. I know the sickle cell group has a huge body of literature on this, and I apologize, I'm not actually up to date on that. I've been meaning to look at it for a long time, but they have a huge literature on this specifically because they get treated very differently. That population gets treated very differently on the adult side than they do on the pediatric side, in terms of everything from pain management, things like that. So acute care is a whole different issue. And this person might be probably referring to coming back to your office and making appointments and things like that. But just to let people know, there is an acute care side of this too, where you can transfer them to the adult side outpatient. But if they come back to the pediatric ER and they get admitted, it becomes a little challenging too. But yes, there's not a great answer to your question. Obviously, the nuclear option tends to be office policies on making appointments and things like that. And that tends to be what I would refer to as sort of the nuclear option. We probably have to have that, and many offices do. But there's hopefully a whole body of work in the middle there where you work with the family to try and figure out what their barriers are about making it. Is it just nervousness? Is it time frame? Can you give them some help in making their appointment? We tend not to make our appointments for the adult, a lot of places will make that appointment for them, and that's great. There's nothing wrong with that. We tend not to, just because we don't know the family schedule and it's very challenging for us to make it. And then most of the families won't keep that appointment. And I think there is some data around if the families make their appointments, they're more likely to keep it themselves. But again, if they don't make the appointment that you give them, it makes it a lot harder. So I don't have a great answer for you. Giving them the referrals, having some sort of a follow-up system is the best I have. Yeah, and the success rates are low everywhere. And this is a challenge for everybody.
That's a good advice. I'll also add that the pediatric subspecialists have similar challenges, and that they send let's say their patient that's seeing neurology,
they send them off, they actually give them some names, and they come right back because, wow, I liked the feeling, I liked the way people treated me better when I was in pediatric neurology. So very, very good point. And
Yeah, take it as a compliment for all of us that they keep coming back.
so Keith Williams had a question about POA info website.
Oh, I think Angela put it in the chat. It's the Illinois Guardian. It's a power of attorney. I'm assuming they're talking about.
Okay.
And it's the Illinois Guardianship and Advocacy Commission comprehensive website. They do have power of attorney on there, right, Angela? I think they will go through.
Power of attorney for healthcare. Yeah, it's gac.illinois.gov. And that's the Illinois Guardianship and Advocacy Commission.
Would you mind also including, you had a number of resources or websites, so it was the GOT transition. If you wouldn't mind just adding some of those checklists, because
Absolutely.
as Dr. Shaw said, hey, let's not reinvent the wheel. And so
Oh,
if
yeah.
you could provide that information and then clinicians can tailor it, I think that would be super useful.
You got it.
Thank you. So now, if people don't have any other questions for Dr. Shaw and Angela.